right. Thank you for the very kind introduction. So today, I want to start framing the conversation about why we're interested in looking at bone by discussing aging, disease, and fracture. So we live in an aging society where our population is set to double over the age of 65 by 2050. And with this comes age-related diseases such as osteoporosis, where there are roughly 8.9 million fractures that occur a year. This equates to 1 fracture every 3 seconds, and the cost of this is quite substantial. Worldwide, 1 in 3 women and 1 in 5 men will experience a osteoporotic fracture. So this is clearly something that's affecting a large portion of our aging population. These are classically, what might come to mind are hip fractures. They're the most maybe debilitating. However, wrist fractures are a common indicator actually for later, more severe hip fractures that occur as a result of osteoporosis. How do we assess this clinically? So when we're looking at patients that come in, we typically take measurements called aerial bone mineral density. You can see this on the right. And this is essentially a way of inferring or measuring the amount of bone in a given area. And while this correlates well with incidence of fracture risk, so you can see the fracture rate in gray increases as the bone mineral density decreases. However, there's a large portion of our population, particularly in postmenopausal women, that suffer a fracture without any clinical indication. If we put this in the frame of the FIDELIO project and we consider how BMD is affected in diabetic patients, we do know that this is altered depending on type. So in type 1 diabetes, we tend to see a decrease in bone mineral density, whereas in type 2, this tends to appear normal. However, we do see with both cases that there's an increase in fragility and an increase in the incidence of fracture. So what's missing in our clinical assessment? What can't we capture? Well, when we look at bone and we try and characterize bone integrity, there's a lot of factors that contribute to our bone strength and its mechanical properties. So we have material contributions, both inorganic and organic, structural properties that contribute to stiffness and strength, and then bone is load adaptive. So our physiological loading can impact our bone strength. Now, if that were at all, it would still be a lot. However, all 3 of these properties will change over time. And there's even other external factors or additional factors that can impact bone integrity. So how do we tackle this when our bone mineral density really only gives us an approximation of structure and a glimpse at the material properties? This is where we can benefit from the finite element method. So here we can capture material structural properties as well as look at the influence of different loads on our bone. So we can take from experimental data, mechanical properties, use imaging data from individual patients, and then also take kinematic data or joint forces in order to apply loading to our models. And this combined could really give us a better picture of bone integrity across the patient population, like for type 1 or type 2 diabetic patients, and can also be used to track changes longitudinally. So we could theoretically track changes in an individual's bone mechanical properties over time. So how do we get there? So high-resolution peripheral quantitative computed tomography was introduced in 2005, and this is really our best option for tracking in vivo changes in structure of peripheral sites. And so this was designed essentially to allow us to take images of the radius and tibia in patients at a high enough resolution that we can measure the microstructure. So there's been 2 generations of extreme CT that have been developed. The first achieved a resolution of 82 microns, and the second, which is now becoming more and more prevalent, has a resolution of 61 microns. And although this gives us high resolution, it still maintains a relatively low radiation dose, meaning that it's not particularly invasive to patients. And as we've seen from some of the previous talks, HRPQ-CT is a strong candidate for analyzing differences in patient populations. So from the BOMIC study, they analyzed parameters that were derived from HRPQ-CT against the clinical standard, here written as femoral neck area bone mineral density. And you can see actually that cortical area was a significant, or had a strong association with incidence of fracture in both the tibia and radius, and additionally trabecular bone density in the radius. And for both cases, failure load was one of the strongest predictors, which you can see at the very bottom of the two plots, for incidence of fracture. And this is likely because it takes into account a lot of other factors than just mineral density. So how do we get from our medical image to a computational model? This goes through a series of steps, but essentially we need to capture the geometry from our image, apply material properties, and select our boundary conditions in order to run our analysis. So for the geometry, we first need to consider whether or not we have longitudinal images. Do we need to register these where we have 2 time points? Are we trying to look at changes over time, or is this a static measurement and we're comparing 2 different patient groups? After registration, we can then convert our image density data into a physical density, and then using literature data, typically we can convert this then using a function of, that's dependent on the Hounsfield unit density and the apparent density in order to generate an elastic modulus. This is going to be then our material properties for the model. And then lastly, we assign our boundary conditions. Typically, this is often in HRPQ-CT data assigned as a high friction compression, where the nodes in the Z direction are fixed at the bottom and a 1% displacement is applied at the top. Often then we can derive material or mechanical properties from these analyses, such as bulk stiffness, or as you saw in the previous slide, failure load. So while this may seem like a smooth process, there are distinct challenges. First, I mentioned that there's different generations of extreme CT, meaning that we have different resolutions. And obviously, while these are improved upon, say, clinical CT, they still don't achieve the highest resolution possible that we could achieve with micro CT. And you can see in the image here that as we go up, or as voxel size increases, we start to lose those fine features. So while we can capture some microstructure, we lose some as the voxel size increases. This has different effects and can be particularly damaging when we're looking at microstructural parameters derived from extreme CT. So on the right, you can see results from a review that analyzed the effects of image resolution on sort of the outcome parameters from a microstructural analysis. So here, BVTV in both 82 and 61 micrometer HRPQ-CT were very consistent. However, when we look at trabecular thickness, particularly for the 82 micron, the range in reported values varies widely. And essentially, when assessing the literature, we should be careful in how we interpret these values depending on the image resolution. And some of these factors that are affected not only by voxel size, but also signal to noise ratio, you can see distinct sort of blurring or cloudiness in the image as the voxel size increases. And again, this is not only related to the voxel size, but also the scanner generation and technology involved. When we start looking at the individual images beyond resolution, we do have issues that can arise because we're taking scans from live patients. So motion artifacts are one of the biggest contributors to sort of loss of data in a clinical study. And this is because it starts to degrade the quality of the image. So you can see in the second image here, in where the top row is radius images and the bottom is tibia, that you start to see a slight streaking occurring in the images that gradually degrades to the point where you start even having breaks in the cortex. As a result, we've introduced a visual grading score that tries to assess the quality of images in a somewhat less subjective fashion. So images of VGS1 are considered to be the highest quality, so no visible motion artifacts, whereas slight streaking will be observed in VGS2 images. However, these are still considered fairly high quality. In images 3, 4, and 5, we start to again see a degradation or a more prevalent degradation in the image quality. However, initial studies have concluded that images of qualities 1, 2, and 3 can be considered for further analysis, given that precision errors for density analyses, microstructural analyses, and failure load analyses are within acceptable limits, meaning that images 4 and 5 are traditionally rejected from imaging studies. Unfortunately, because this is a manual grading, there are oftentimes disagreement between operators. As a result of this, a recent review on sort of guidelines for how to approach extreme CT imaging studies, they've now suggested that images that are rated with a quality 3 should actually be considered for a rescan at the time of appointment, rather than being included in further analyses, given this margin of error between operators. So these motion artifacts are a product of the technology itself. Standard image reconstruction assumes that there's no subject movement, and while it may seem like in a span of 2 minutes, patients should be able to hold still, it still happens frequently. And because of the projection-based nature of computed tomography, any slight motion during scanning can result in essentially a shift in the scenogram shown on the right, which then results in observed motion artifacts in the reconstructed image. There have been attempts to overcome these limitations using machine learning approaches in recent years to at least quantify the amount of motion within the image, and then also to try and correct, although these are not part of the standard manufacturer software and really aren't implemented clinically. Here you can see an automatic grading score that was developed in order to determine sort of the amount of motion in an image, where looking at projections at the 0 degree and 180 degree and subtracting the two after one of them was mirrored. And you can see in the grade 5 image that there's quite a bit more difference detected in the subtracted images. So provided you're able to collect your data, the next step is really image segmentation. So you need to be able to select your bone of interest and isolate it from the background. So in the default manufacturer pipeline performs an image segmentation protocol that not only separates out, for example, the radius from the rest of the image, but also then isolates the cortical from the trabecular regions. And this standard approach was identified to try and help sort of separate out this periosteal and endosteal margins within the distal radius or tibia. So here we show distal and proximal slices from a radius that's been segmented, and you can see the cortical and trabecular regions highlighted in purple and green respectively. Although this works to some extent, there are concerns with the standard approach, namely that this approach doesn't account for changes within this sort of cortical compartment with time, where we know that there can be degradation in the cortex as we age, with essentially endocortical trabecularization chipping away at the cortical shell, resulting in sort of an over-aggressive estimation of cortical bone loss, when in reality, we're now attributing trabecular or cortical bone to trabecular regions. So Zebaze et al. Introduced a 3-compartment method where an additional zone was identified, referred to as the transition zone, such that the cortical and trabecular regions were more stable over time, and you could actually track this change in sort of this susceptible endocortical region. However, none of the segmentation protocols that exist today really perform well for all computational applications. So although there is a default manufacturer pipeline, often studies will implement their own segmentation strategies. Some of this is because the default manufacturer pipeline often fails, and requires significant manual correction. Here you can see a few different instances where the manufacturer pipeline was unable to isolate the radius from the background. So there can be issues where there are missing parts of the radius. The ulna gets included because there's not much spacing between the radius and ulna, perhaps as a result of sort of degradation in the joints with arthritis. And a combination of the two, as well as you can see that as visual grading score degrades, it becomes harder and harder for the default algorithm to be able to isolate the radius. More recently, our group has actually introduced a geodesic active contouring approach that's fully automated. And while it doesn't overcome all problems, it is much more consistent and doesn't require manual fixes when segmenting out the distal radius. Additionally, we initially introduced this algorithm to tackle issues related to fracture, where the default pipeline is unable to handle breaks in the cortex. So there are techniques out there that are looking at improving this side of the analysis pipeline. So once you have your images, you've segmented them, now you need to start looking again, if you're considering longitudinal data, how do you compare these over time? So again, as we're scanning patients and they're coming in on different days, there's a high likelihood that there'll be positioning errors when the patient is coming in from time point to time point. And this can result in differences in the positioning, whether they're axial, so they could be potentially positioned further forward or backwards, and as well as the more sort of dangerous is the tilt within the arm, despite the fact that they're in a brace within the machine. So the default manufacturer pipeline includes a 2D cross-sectional matching registration approach that essentially tries to match the total cross-sectional area of each slice to determine an optimal offset to fix any issues with this sort of axial displacement. However, it's unable to correct for any issues related to tilt. Often, studies will employ a 3D rigid registration approach that can account for both of these factors, both axial and tilt. However, this is a relatively complex optimization problem and is susceptible to noise and motion artifacts. Briefly, this process essentially uses an initial global registration on downsampled images, and then it's iteratively fit using an optimizer in order to come up with the sort of the best fit. However, the main advantage of this process is that you're now able to do more local analyses that would not be possible using the 2D registration approach. Of course, in both instances, visual inspection is still needed in order to verify that your registration was successful. Now that we have our images, we know that they're good quality, we've segmented them and registered them, we need to consider how we want to apply the loading conditions to our models. So often we have to approximate the loading conditions in vivo, given that the segment that we have of the radius is relatively small and does not include the whole bone or even the whole joint space. Typically, we assume a high friction compression, both at the radius and at the tibia, which is relatively easy to implement. So I briefly described it before, but one of the downsides of this sort of fixation and uniaxial or this axial compression approach is that it tends to overestimate load that's being transferred through the cortex. So you can see in the image here that there's relatively significantly higher strains in the cortical bone compared to trabecular, which may not reflect what we would expect to some extent in at the articulating surface. Another strategy is what's referred to as padded compression. This essentially was developed in order to try to reduce the issues with end effects by, rather than applying a loading directly on the nodes, using a boundary layer with different levels of stiffness to try and match in vivo loading that was observed in a full radius. So here cadaver data was taken of a distal radius, and then the standard kind of extreme CT image stack was then applied with a series of boundary conditions to try and determine which set had matched the sort of whole radius scenario. And here the load was actually transferred onto the articulating surface using the scaphoid and the lunate. More recently, there have been hybrid boundary condition approaches that try to optimize sort of both of these approaches using a continuum model and a micro-FE model. The continuum model is usually generated from clinical CT data, so it's a much lower resolution, and then the micro-FE model is the standard position, and these are mapped onto one another such that you can more naturally sort of transfer the loads through the radius and avoid these issues with additional or excessive load transfer through the cortex. However, this is a much more complex implementation, and it does require additional radiation dose for the patients. So now that we've generated our model, we've applied boundary conditions, how do we actually look at the model performance? How do we determine sort of the bone behavior, what's a strong bone, what's a weak bone? So classically, when we're looking at mechanical properties of any material or tissue, we can differentiate them into structural and material properties. So structural properties are going to be the response to a force or displacement. So here you can see that the force versus displacement curve shows this sort of linear region where we can derive the stiffness of our material or stiffness of our structure. And then as it starts to fail in this orange nonlinear region, damage is occurring and up until the point of failure. Converting this to stresses and strains by, in the compressive case, normalizing by the cross-sectional area, we can see then that this behavior is carried over, but it's no longer dependent just on the structure we're looking at. And again, we have this sort of yield region and up until failure. Now, what I've talked about up until now have been FE analyses that are really focused on linear modeling, and this is because it's much less computationally intensive. There are models out there that look at nonlinear finite element analysis, but when we're trying to consider micro-FE models that have billions of elements, this really isn't feasible, particularly if we're trying to translate this into clinical applications. So in order to compensate for this sort of linear FE trying to model failure criterion have been introduced. So the first and perhaps most prevalently used is what's referred to as the Pistoic criterion. And here bone is determined to yield when a specified volume exceeds a set critical strain. So you can see in this sort of strain voxel curve that at a certain max or kind of critical strain here set to 0.7% strain, when 2% of the voxels within the image exceed that strain, we consider it to have yielded or failed. So this would be essentially that failure load that we've talked about that's so discriminatory in terms of predicting fracture. Now, often the values that are set for these failure criterion are different between the imaging resolutions, where the one I described applies to 82 microns, whereas 61 microns studies have looked at or have sort of adapted these parameters because of the increased resolution. And note that the original study where the failure criterion was developed was on 165 micrometer resolution. So there have also been recent studies that suggest the 82 micrometer failure criterion should be adapted. So now that we've been able to look at sort of stiffness and failure, is there more that we can do given that we have, especially in the case of longitudinal data, this sort of ability to look at local mechanical properties? So we know that bone adapts to loading. So here is sort of the classical mechanostat, where we have sort of this physiological loading range where bone is happy. Sometimes this is called the lazy zone. It's what we expect. It's what our bones are happy with. There's not, you know, there's this sort of metabolic balance regarding bone turnover. And then you have this overload window where if you have applied or high enough strains, the bone starts to adapt and increase or stimulate formation of bone. Conversely, if the strains are too low, our bone tries to modify and remove anything that's unnecessary. So low strains are then associated with bone resorption. And obviously at the highest end of strains, we consider this to be pathological, and this is where you start to see damage accumulation and fracture. And there have been studies that have linked this then, this mechanostat in vivo. Prior to, let's say the mid-2000s, much of the research had been done in animal studies looking at this sort of mechanoregulative behavior of bone. But with HRQ-CT, it was now possible to start looking at within patients in vivo how their bone changed over time. And then using finite element analysis, we can simulate the mechanical loading and then relate these packets of resorption and formation that we can determine from overlapping images to, again, this local mechanical stimulus. And what we know to be true is that these remodeling sites really do correlate strongly with local tissue loading, where formation is in regions of high strain and resorption is in regions of low strain. And this has been further confirmed in a very recent study from last year, where active loading can actually be used to increase bone volume. So there they had patients essentially load their distal radius and looked at changes over time and sort of was able to confirm what we've seen in, again, animal studies predominantly, that we can sort of induce a positive adaptation in patients using loading. So how can we apply this to our diabetic patients? So we know that, as I said, mechanoregulation is an important regulator for bone health, where within this sort of lazy zone, bone's happy, it's doing its thing. We can shift towards formation in high strains versus low strains. And this behavior is all really being driven by individual cells within the bone tissue. And with our high resolution imaging, we can essentially directly measure the output of these cells on the bone surface. And if we look at this in terms of, again, a diabetic perspective or in a healthy versus diabetic patient, you know, we can consider, so here on the right, you can see again this relationship between formation and resorption. We can generate these conditional probability curves. This is a representative one, but this can be generated from our patient data, where we can determine sort of this threshold for what strains are associated with formation versus resorption. And this sort of individualized mechanostat can be used to determine perhaps patient health. So in a healthy adult, maybe we have this relationship. Whereas in a diabetic patient where there's reduced bone turnover, maybe we expect, or maybe we could hypothesize that perhaps this lazy window is larger, where there's either not enough stimulus, or the result of this poor glycemic control can kind of reduce the sensitivity of the cells. So it either takes more stimulus to enact formation, for example. This could be used potentially to explain some of the differences we see between type 1 and type 2 diabetes patients, where we talked about before. There's low BMD or BVTB in type 1, but not necessarily in type 2 diabetes patients. If we put this in the frame of physiological loading, it could be that body weight, so in type 2 diabetes patients, you often have the comorbidity of obesity, and this increase in body weight could be pushing towards higher loads within the bone and acting as sort of a protective feature at bone loss, or kind of counteracting the reduction in turnover that would naturally be occurring in type 1 diabetic patients that don't necessarily have obesity. And we can see that this, when we match for body weight, that this sort of difference does tend to narrow. So body weight definitely plays a role in how our bone responds, and it seems to be a key factor in diabetic patients. We've talked about before the ability to measure sort of microstructure with the image data. In terms of what parameters are affected by diabetes, this is somewhat contested. Cortical porosity is often a target for, or identified as different between healthy and diabetic patients. Although, as from the last presentation, this can be somewhat contested. However, this type of analysis would allow us to look at where specifically bone is being lost, as opposed to just changes or differences between cohorts, or even differences in the individual parameters, where we wouldn't be able to do that without the registration process. In total, I think this tissue level analysis really has the potential to determine appropriate targets for treatment for diabetes. So if we can derive these sort of mechanostat curves for diabetic patients, both with or without neuropathy, different comorbidities, potentially this could reveal again, this sort of cellular behavior in an indirect way, allowing us to come up with differences in approach to which pharmacological treatments would be more appropriate. And not only does this work on a population level, but given the data and enough patients, this could also be something that's used as something for personalized medicine. With that, I'd like to thank you for your attention, and I look forward to your questions.